All right, so welcome everybody. I'm going to talk today about demyelinating disease. And yes, the talk title is More Than 50 Shades of Gray. It's a play on the fact that demyelinating disease is usually thought of as a white matter disease, but it's much more than that. And I have a grant currently, actually a couple. There's one that's missing, another grant from the MS Society working with a neurologist at Lenox Hill, developing brand new MR technology to diagnose the acuteness of a lesion, which is really, really important in MS. So we'll review what this diagnosis is. It predominantly affects younger people in their 20s and 30s. We'll talk about some variations of demyelination when the white matter sort of essentially loses its insulation. Myelin sort of wraps around neuronal tissue and it acts like an insulator. It's mainly composed of fat, and we're going to talk about that. There are a lot of atypical forms of demyelination, which are really interesting to us, and I'll spend the next half on this emerging technology, a sequence called T-Monroe that we worked on developing a few years ago, and myelin mapping, which is a hot topic. It's a big part of a national initiative to map the connectome and to understand how our brain is connected. And then a new sequence developed by a friend of mine at the NIH, which can really kind of definitively tell us when a lesion is an MS plaque versus a normal spot related to aging. This I don't expect any of our, brain terms to really understand, but this is basically just to tell you, for every time that a patient gets a scan of brain MR, we have a dedicated protocol. And the important thing in this slide is just this flare sequence. It's kind of a very special way to image the brain where we suppress the cerebral spinal fluid signal on the MR image, and I'll show you pictures, and it really highlights pathology in the white matter. And diffusion weighted imaging is very, very important. This was invented less than 20 years ago, essentially, and it's actually able to detect changes in the microscopic movement of water on a cellular level and on every single voxel element of that MR image. And that's really kind of revolutionary when you think about it. We actually have a technique which is sensitive to the translation of water movement, and we can actually quantify that value. So here's a typical example of a research volunteer who has a bunch of these areas that are hyper intense where my arrow is. These are very characteristic along white matter pathways we call callosal striatal, because this structure is the corpus callosum. It actually connects the two hemispheres. And all these things that look bright are not normal. If we go to the next slide, you can see all of these areas that are like little spots are all abnormal. These are characteristically located in the white matter. This is in the corpus callosum in the body, and they have a particular orientation where they're perpendicular to the long axis of these structures which contain CSF called the lateral ventricles. And we give contrast. Now, contrast is really important in a lot of imaging studies that we do as radiologists, because whether it's this particular disease, demyelinating disease, or a brain tumor, there's often disruption of the blood-brain barrier, which I'm sure you'll hear about. And this blood-brain barrier is really important. And because it gets disrupted early in MS, you get a lot of inflammation. It allows lymphocytes to cross through this blood-brain barrier. And we'll talk a little bit more about that shortly. But in essence, all these areas that you see that I'm pointing out are areas of abnormal enhancement. This looks like a donut ring. That looks like a little spot. That's an incomplete ring. These all represent areas where that blood-brain barrier has been disrupted, and you have active, acute multiple sclerosis. Every like 7 or 8 years, a bunch of the world's experts in MS get together globally. It's called the McDonald criteria, and it spells out very specifically how you make a diagnosis of multiple sclerosis. This is really, really important because we want to share information globally. We want to have a common language by which we describe things on imaging, and a common language to make a diagnosis. So that way we can engage in multinational global treatment trials to affect changes in multiple sclerosis. So we're all on the same page. You look for these elevation, these things called oligoclonal banding, which is a hallmark of multiple sclerosis in the cerebral spinal fluid, which you obtain through lumbar puncture. Disseminated in space means you have more than one lesion, those bright lesions that we saw previously in these characteristic areas, which we'll talk about in just a little bit. The posterior fossa, spinal cord, I'll show you in a little bit, but we'll talk about the white matter, both periventricular and juxtacortical. The Magnum's group also adds cortical lesions to this diagnosis. And the key thing about multiple sclerosis for a neurologist is they diagnose this based on dissemination in space and time. So you have these symptoms related to white matter tracts. It may be double vision, numbness, tingling, weakness. It really depends on where that lesion is located. But you have to have them in more than one location in the brain for the dissemination in space, and you have to accrue new symptoms over time for disseminated in time. With imaging, there's a correlation. Basically, if you have an asymptomatic gadolinium enhancing lesion or a non-enhancing lesion at any time, or any new lesion that occurs over time, with or without enhancement, can be considered disseminating in time. That's a little bit technical, but things were revised in 2017. This is the latest iteration. The experts around the world really recommend you get a brain MR at the time of diagnosis of MS. We typically do brain and spine imaging here at Lenox, and you want to make sure you look for both symptomatic and asymptomatic lesions. They can be used for dissemination in space and time. The big critical unmet question is, can we detect active lesions or not? And how does that relate to disease progression? You know, it still is this clinical diagnosis. There are lots of mimics, but the reason why we obsess so much about this is that there are many studies that have been done that show if you diagnose it correctly, quickly, and you start therapy, you have a longer duration of disease-free living, less long-term disability, less relapses, because most patients with multiple sclerosis have this waxing and waning course. So let me show you some pictures. This is a CAT scan, and I'm pretty much an MRI snobby kind of guy, but here's the CT, and I'll show you why in a second, why I'm snobby about MR, which stands for magnificent radiology. You have two lesions here that look low density, and these are in the white matter. This is cortex, this is juxtacortical white matter, subcortical white matter, another lesion. When you go to the MR, wow, same patient, same day. The MR is just much more sensitive. It picks up many more lesions. So here you have lesions that are juxtacortical, subcortical white matter, both. There may even be cortical lesions, but there's really extensive disease. But all of this is a flare image, by the way. So the white matter looks black. The cortex looks brighter, if you will. Not as bright as the lesion, and some of that brightness represents pathologic water accumulation. But this black represents white matter. This is the corpus callosum, which connects the two hemispheres. But all these areas that are darker on the image represent white matter tracts. This is the primary motor cortex, which controls, you know, your upper and lower extremity. This in particular represents the hand portion of the homunculus. And you can see that there's involvement of the primary motor cortex. This person probably has left-sided weakness, because remember, this is the right hemisphere. And actually on images, we have, just to confuse the neurosurgeons whom we love and work with, this is right and this is left. It's not your left and right, but this is just how it is. So this is actually the right brain. And of course, a lesion here affects the left side of the body. And again, this is the temporal lobe, right? And we have a couple of lesions here. Now this structure here represents the midbrain, and this is midbrain heading into pons. There's a structure here which connects the brainstem, the superior pons to the cerebellum. There's a lesion right there. And again, this is the contrast was given through a vein, and there's lots of enhancement. So all these things which look bright on this image represent abnormal enhancement. So really pretty significant amount of MS. And again, this is the cerebellum, this is the pons, this is all considered posterior fossa, and there's a lesion enhancing there. So this person easily meets the McDonald's criteria, correct? Because they have a lot of different lesions. Now this person was a special case. Most patients with MS have a relapsing and remitting course, but some people have a really bad variation where they're considered primary and progressive. So they just have more severe variation of the disease, a different phenotype, we would call it. So in addition to steady progressing disease, you have to have these other conditions met positive CSF, cord lesions, and then more than a couple of these white matter lesions in these characteristic areas. This person met the criteria. So now here's an example of imaging of the spinal cord, which you may or may not have seen before. But this is the spinal cord. This is tongue, chin, cervical vertebral bodies. This is the base of your head. And so this is your cervical spine, your neck region, right? And this is tracheal air column, just for orientation. This is anterior, posterior. So here you have a lesion inside the spinal cord. It's characteristically involving the posterior columns, which is white matter. And the spinal cord is different than the brain. The white matter is on the outside, the gray matter is on the inside. Actually, it's similar, never mind. But anyway, you have cortex sort of peripherally in the brain, but not to be confusing, this is the posterior columns. And there's this, again, broken ring of enhancements. This is an active, what we call an MS plaque, a multiple sclerosis lesion, which is active. But when you see this lesion, what do you do next? So here we have these pearls of wisdom, which we, in radiology, when we train our residents and fellows, we talk about these pearls of wisdom. So when you have a lesion here, you have to image the brain and the rest of the spinal cord. It really, really matters. And this person was developing a secondary progressive form of the illness. Look at all of these different lesions in the white matter, again, corpus callosum. So pretty bad disease. And again, these classic incomplete rings of enhancement are very characteristic of multiple sclerosis and demyelinating disease. These are the different kinds of clinical presentations of MS. There's another kind, which is a hot topic of research, clinically isolated syndrome, where most of these patients will go on to develop fulminant MS with an abnormal brain MR. And anyway, the therapy we won't spend too much time getting into, because I'm going to focus a little bit more on mimics of multiple sclerosis because the images are interesting, and then we'll spend some time on research sequence development and what that's like if you choose to go into a medical career where you do a little bit more research. And imaging is fascinating. I would argue that imaging is central to every single specialty of medicine. The basics of MS therapy are immunomodulatory therapy. What does that mean? You manipulate the immune system in some way to try to improve MS and reduce the likelihood of a recurrence. When you have an acute exacerbation or acute symptoms or plaques that are enhancing that are acute, steroids are initial first course almost always, like Solumedrol. If you have really aggressive MS, you can get chemotherapeutic agents. Most patients who have really aggressive MS will get monoclonal antibody therapy like Tisabri, and that's particularly for really badly progressive MS. And you want to watch for complications related to some of this therapy. So there are a lot of diseases where the immune system is overactive. MS is probably one of these, in which your body is making an antigen to receptors or to other structures which are sort of destroying myelin, and it's related to a porous blood-brain barrier. We'll talk more about that specifically with a particular receptor at the M plate of astrocytes, which are cells at the blood-brain barrier. And also for patients with rheumatoid arthritis or psoriatic arthritis, those are also inflammatory arthritis, arthropathies or arthritic conditions. And all these patients get put on very powerful therapies which really suppress the immune system. But when you do that, they're at risk of getting other complications. And one of them for MS is you can risk getting progressive multifocal leukoencephalopathy. Now that's a disease where you get reactivation of this Jakob-Creutzfeldt virus, or JC virus. JC virus. And this is what it looks like, this really large area of abnormal bright T2 signal. If you go to the diffusion weighted image, you have this leading edge of high signal, and that's the leading edge where there's been destruction of myelin. In the setting of an MS patient on these therapies, it's a pretty powerful predictor that that represents progressive multifocal leukoencephalopathy, which there is a therapeutic option at this point. You would stop the therapy. You would reconstitute the immune system, because you don't want to have PML, because it's really not curable, and you don't want to have permanent loss of neuronal function here. We'll just leave it at that and not get into too much more. So now NMO is something I don't think any of you have ever heard of. It means Neuromyelitis Optica. It's a kind of inflammatory demyelinating disease. It is a very big hot topic now in the neurosciences, and I'll tell you why. And we'll start with a case. So again, here's the spinal cord. This is the thoracic region. So you're seeing some black signal here. That's actually heart. Some of your heart and descending thoracic aorta. And you have vertebral bodies. This is the spinal cord, and you can see it has too much high signal. And there's this abnormal enhancement. Now, again, as we learned earlier, when you have an abnormality in your spine, you want to image the whole brain. And this is a very specific part of the brain. So again, this is what we call the temporal lobe, occipital lobe, the really tippy top of the cerebellum called the vermis. This is the midbrain. Now in here, we have a structure where different anatomic things exist, like the hypothalamus. And this structure here is actually the optic radiation. And this is the optic chiasm. And that is like cranial nerve number 2, the optic nerve for vision. It's really important. So this person probably has visual symptoms of some kind like diplopia, and there's abnormal enhancement. And when you have this lesion in the spinal cord and optic nerve, it's really pretty classic for what we call neuromyelitis optica. Now, these days we give it a different name, and we call it a spectrum disorder because it's really a spectrum of pathology that occurs in imaging. And the big point about this slide is that everything I learned in medical school is actually pretty much wrong now, which is why I like, neuroscience and medicine, because it really is about lifelong learning. And what you learn in medical school, of course, you have a lot of things you learn in medical school. I advise all of you the most important lesson in medical school is to develop an architecture or framework by which you accumulate new knowledge and throw away old knowledge you don't need anymore. So it's a way to condition yourself to actually be a perpetual learner, because everything changes as we learn more and more things about different disease processes. We have to sort of understand them, take them in, and then reevaluate our knowledge base and move forward with the science. And we used to think that you had to have both an optic nerve lesion and a spinal cord lesion, and the optic nerve involvement had to be bilateral. And this is all just false. And it really, and boom, double false. But it's really a very interesting disease where it's often multiphasic, recurrent. The disease in the optic nerve could be separated by years from the spinal cord involvement. And so it's really, and we're learning more about this disease. So it is relapsing. It's an inflammatory demyelinating disease, just like multiple sclerosis. It is much more common in Hispanics and Asians, especially in Asians. It's a much more predominant phenotype and much more common in women. And here astrocytes tend to be damaged more. But the big news is that there is this water channel along the end feet of the astrocytes of the blood-brain barrier called aquaporin-4 or AQP4. And it acts as sort of a homeostatic mechanism for water transit at that blood-brain barrier level. It has an important role in glial lymphatic function, which I should talk about another time. And this is a simple blood test now where you can test for an antibody to that receptor. So basically, people with this inflammatory demyelinating disease are making an antibody to this AQP4 receptor, and that leads to the development of demyelination along the optic nerve, preferentially spinal cord. So this is pretty interesting to have this blood test. It's commercially available, pretty specific and sensitive. So to make this diagnosis now with McDonald's criteria, we have to have optic neuritis, meaning a lesion of the optic nerve pathway, a spinal cord lesion, and then 2 or 3 of these following to make that diagnosis. Now, a lot of patients with this neuromyelitis optica spectrum disorder don't have those antibodies to AQP4. So, oh my God, it's actually have this other process called an antibody to MOG or MOG. So OMG, it's MOG. And this MOG syndrome is really another hot topic. So there are lots of receptors at the blood-brain barrier. And another one is this myelin oligodendrocyte-glycoprotein complex. So if you make an antibody to that, you'll have imaging which looks like NMO related to the antibodies made to AQP4, but this is going to be made to another compound. So there are lots of interest in the neuroscience world about this blood-brain barrier, because if you make antibodies to certain receptors, you get inflammatory demyelinating diseases that are slightly similar in how they look, but very different. So if you want to develop therapy, you're going to have to target a different antibody. Let's just show you a nice example. Here's a 30-year-old who presented with incontinence, meaning inability to control urination, and paraparesis, so sort of weakness in all the extremities. If you look at the spinal cord here, there's this high signal that is completely going down the entirety of the cervical and upper thoracic cord. It's expansile. It's involving the deep gray matter, like that is edema in the central part of your spinal cord. And then if you look here, it goes all the way down the thoracic spine into your upper lumbar spine. So it's sort of to your top of your lumbar back area. The entire spinal cord is involved with this pattern of abnormal hyperintense or bright signal. And if you look at the brain, you have abnormality here of the dorsal pons or dorsal brainstem, the thalami bilaterally. There's cortical involvement that looks abnormal. Like this is the normal cortex. See that thin little ribbon? And this is all expanded and too bright. So they also had no enhancement. So they had anti-MOG antibodies. The diagnosis is NMOSD, but it's really anti-MOG syndrome. And this is treated with steroids, and 3 months later on follow-up, all those images looked improved and all the lesions have gone away. Now, I think it's really important to learn from our mistakes. I think the last speaker, the neurointerventional stroke physician, really had a salient comment. We learn from our mistakes, and it's really good to share those with people we train. As a good mentor, you have to do that. And so here's a case where someone had some back surgery, and they had this abnormal signal in distal cord, and there was really some concern that there was some ischemic damage to the spinal cord, which may or may not have been related to the surgery. And you know, I did a lot of diffusion MR research, and I thought, okay, I'm going to be super clever. And we did diffusion weighted imaging, and this is like classic look for spinal cord infarction. However, it is very, very sensitive, this methodology, but it's not entirely specific. So one of the things in imaging that I think is important for all physicians to understand, especially those of us whose lives are completely devoted to this, sensitivity and specificity are not just statistical things that annoy us on undergraduate exams like it did me, but they're really critical because every procedure that we do, every test that we order has this balance, how specific, how sensitive. And so this person didn't get better. And the interesting thing is if you have a focal infarct or stroke of the spinal cord, it's focal. It shouldn't be progressing over time. And this one was progressing over time, involving much more of the thoracic cord. So it started down at the distal thoracic cord and started moving north up into the upper thoracic area. And it's right on diffusion. This is really classic for anti-MOG syndrome. It tends to be a spinal cord process that starts at the distal thoracic cord and conus area and moves northward. And so this was the pearl of wisdom, right? It was anti-MOG, and not everything that's bright on that diffusion sequence is a stroke. So there's like lots of pearls of wisdom here. There's another example of anti-MOG syndrome. There are some atypical demyelinating diseases that are very, very rare. These are very, you know, a lot of those who go into radiology are really interested in all the zebras and not the horses. Like horses are diseases that happen commonly, like multiple sclerosis. But the zebras are the ones that really get our attention because they're like wickedly cool. And these are some zebras. Here's an example of a real zebra. It's a 29-year-old who presented with a seizure. And this really looks like a GBM, a glioblastoma, Dr. Bookvar's specialty. It really does. You've got your corpus callosum here is really expanded, tons of abnormal edema signal. And this is the subcortical white matter, the right frontal lobe, left frontal lobe. There's mass effect, like this structure here is the lateral ventricle, which has dark CSF or cerebrospinal fluid signal inside it. And so this really looks like a high-grade glial tumor, except she's 29, which is a little bit unusual, but it can happen. And here there's no abnormal enhancement. Some higher-grade glial tumors may not have so much enhancement, but the key to this case is the diffusion imaging. And this is like your best friend. So there are lots of pearls of wisdom we'll review at the end of this topic, so I'll make you all into expert neuroradiologists for inflammatory and demyelinating disease. This marks, again, the leading edge of myelin destruction, just like that case of progressive multifocal leukoencephalopathy as a complication to therapy for MS. Same kind of look. And this represents a very fulminant form of MS called Marburg Variant. Marburg was a neurologist at Columbia Presbyterian in New York City, and he described this. You know, he incidentally was a refugee from World War II, so we love all of our foreign. A shout out to all my friends who are international students studying medicine in America. We love you and need you. So Marburg described this syndrome of basically a very aggressive kind of MS, which is mistaken for GBM. Here's another example. This one has enhancement. You would think it was a GBM, actually. Here's another example of a very large, non-specific, big, bright blob, if you will. Yeah, there's a big, bright blob in the left frontal lobe, and it has this incomplete ring of enhancement that is classic for a tumefactive multiple sclerosis lesion. This is a sequence called proton NMR spectroscopy. We don't have enough time to get into the details, but I'll just tell you that this represents the accumulation of lactate. So whenever you do exercise and feel soreness in your muscles, it's because you have a lactate buildup, but you can get lactate in your brain. Remember, your brain takes 25% of your cardiac output, very highly metabolic organ, sucking down lots of glucose. So if you have inefficient metabolism, you're gonna get lactate buildup, which isn't good. This peak is choline, a marker for membrane stability, and it's not so stable. And this is a classic tumefactive MS lesion. Tumefactive just means it looks like a tumor, but it's not. And it just represents a variation of presentation. Here's another variation of how an MS plaque can look like. This almost looks like a hurricane symbol on a weather map. You have these rings and of different appearance, right? You have sort of these really subtle rings of bright, dark, bright, dark, bright, dark, and that represents a variation called Balo's concentric sclerosis, and even has enhancement that skips every other layer, so to speak. And it just represents a variation of demyelination where you have this attempts at remyelination surrounded by demyelination. It sort of spreads outward in a centrifugal pattern, almost like a donut or one of those hurricane symbols on a weather map. And again, it tends to portend a worse prognosis, which is why we care about it. And let's move on to a couple more examples. Here's a 3-year-old who has, again, a very long lesion in the thoracic spinal cord. It's expansile, a little bit of enhancement. Remember our pearl of wisdom: when we have a lesion in the spinal cord, we have to image the entire central nervous system. So go to the cervical spine, there's another lesion, it enhances. And if you come up to the brain, you'll find there's a bunch more lesions here. And this is called ADEM, or acute disseminated encephalomyelitis. And this is a very common form of demyelination in children. Typically, we see this after an upper respiratory infection or a virus. It's often such a subtle cold or a virus, there's no recollection that it happened. It can mimic meningitis occasionally. So these kids will get a lumbar puncture. We look for things to make sure they don't have an infection. Classically, you see an elevation, this myelin basic protein in the cerebrospinal fluid. And you shouldn't get new lesions within 6 months. And if you do, you might consider that the kid may have multiple sclerosis. It is unusual for kids under the age of 11 to get it, but you can. And depending on how bad this ADEM is, determines the kind of therapy. It can be steroids, immunoglobulin, even plasmapheresis, where you exchange plasma to try to get rid of some of the antigens that are spurring this immune response. And again, we've talked about this. I'm going to move on for sake of time. You could, if you have there's a variation of this, which is much more fulminant, where some of these lesions become hemorrhagic. Again, these are white matter lesions that are in the deep white matter and corona radiata. This is the brain stem. There's a white matter tract called the middle cerebellar peduncle connecting the cerebellum here to the pons. So this is a diffusion image showing that they're all probably active and acute lesions. And again, some incomplete rings of enhancement. And this was actually called, it's called hemorrhagic, acute hemorrhagic encephalomyelitis, or Western Hurst syndrome. Very, very rare. Typically a very poor prognosis, and it's a very fulminant form of demyelination in very young children. So this we do want to diagnose correctly, quickly. My last case before we get into some research, which to me is more interesting, like how can we really get at understanding this a bit better? A college freshman with psychosis. I have 2 or 3 cases of this. It's a rare kind of inflammatory demyelinating disease, but typically it happens in college students. And this person was admitted to the hospital with psychosis, meaning that they were not grounded in reality anymore. And they were in an inpatient psychiatric unit. And then my good friend came back from their vacation, and she was the attending on the ward and said, you know, I think this person does not have schizophrenia. I think this person has something organic, meaning there's something wrong with the brain. And sure enough, we did an image. There are all these abnormal lesions in the cerebellum here bilaterally, the pons, in the deep gray nuclei, like that's thalamus, caudate, some of the white matter, as well as quite abnormal, a little focal dot in the corona radiata. And there's all this abnormal enhancement. The key was on this image in the corpus callosum, this little hole in the corpus callosum. The body is like a pathognomonic sort of feature. And this is a very rare entity, again, called Susac Syndrome. And this Susac was also another neurologist who worked at Columbia. It's not a conspiracy. There's just a lot of good neurologists at Columbia. Classic triad of encephalopathy, branch retinal artery occlusion, and hearing loss. This person presented with encephalopathy. So and that could be really very similar to psychosis, actually. I mean, people who are encephalopathic will see hallucinations, so it's not faulting anybody. So they were encephalopathic, psychotic, but if you're in that state, you're not gonna be able to elicit a history of hearing loss or visual disturbance. Now, this actually has a female predominance. It's self-limited, steroids treatment are usually effective. And our patient had lesions in all these places that have been reported, like paraventricular and subcortical white matter, corpus callosum, brainstem. And what's new in the horizon? Because I really care about research a lot. And the really big hot topic in MS is cortical plaque detection, because, and this is pointing out areas of the cortex that look a little bit funny. This is a T1 weighted image. This is a FLAIR image. This is good for anatomy. This is good to look at subtle pathology, like these little bright lesions there correspond to those dark spots there. And cortical lesions matter because it's gray matter, that cortex. Cortex, which it enables us to be the thinkers that we are. It separates us from other mammalian species, right? And if you have a lot of cortical disease burden, you have less good outcome long-term and more disability. It's going to affect your ability to think and all kinds of other higher executive functions. And that's what this article is in reference to. Now, early in MS, there's this blood-brain barrier disruption. These tight junction proteins get expressed, and there's abnormal anionic exchanging occurring that allows these really aggressive T cells to cross the blood-brain barrier. And they're going to incite a lot of infiltration with cytokines, leukocytes, and axonal loss occurs. And this happens very early in MS. And there's a really great paper that came out of the Mayo Clinic and like a decade ago, Lucanetti's group, where they actually biopsied early MS patients with normal brain MRs. They went after biopsies of the subarachnoid space and cortex, and they found that 40% had cortical plaques, more than 80% had CD3 markers, and 40% had macrophage-associated demyelination, meaning macrophages were in the cortex chewing up myelin. So very early in MS, there's a cortical disease. You can have different kinds of plaques. This is going to be a subcortical plaque, subpial plaque, purely intracortical, juxtacortical. And this is just showing a graph, how many had macrophages, how many had these T cell inflammatory markers within plaques. And here's just some examples on histopathology. There's all these represent inflammatory infiltrates around blood vessels and plaques and in the subarachnoid spaces. So clearly it's an inflammatory disease very early on. So how can we do this with imaging? This is what I really live for. It's my passion, is to try to come up with new ways to image the brain. And if I can't come up with it, I'm going to work with other people who are. So in the MRI world, these guys developed this really interesting concept, because myelin, if you divide a T1 by T2 weighted image, you're going to maximize myelin signal. And here's some example of showing you some of the myelin central sulcus. This is the primary motor cortex, primary somatosensory cortex, regulating pain and temperature. This represents where myelin is greatest. And we know that myelin is relatively hyperintense on T1. It's relatively hypointense on T2. You can actually do a mathematical calculation, divide one image by the other to maximize signal coming from cortex, which is what you do. This is an example of that, where you divide T1 by T2 just like this. And this was developed by Glasser's group in Van Essen and Washington University of St. Louis. And you're going to enhance your ability to detect myelin in the cortex. And that's great, because if you have early lesions in the myelin in the cortex, we should be able to see it. And you use this software to sort of, which is part of the Human Connectome project, where you can actually strip away the skull, and you can actually segment out different tissue constructs. This outlines the cortex. That's going to outline the boundary between cortex and juxtacortical white matter. And then you can get these beautiful maps of myelin. So here you have the motor cortex. This is the front of the brain, the back of the brain. This is occipital lobe, motor cortex, and somatosensory cortex. And why are those areas so heavily myelinated? That should make sense to you, all of you on this talk, because When we're born as little babies, like, right, babies can cry, they can grab onto your finger. So the motor cortex and that pain and temperature sensing cortex are vital to our survival as a species and true for every other animal, as is the occipital lobe for vision. These are primary senses upon which all life is really dependent. And they're going to myelinate first. In fact, all the higher executive functioning that we do in dorsolateral prefrontal cortex, that doesn't fully myelinate until our 20s. And it myelinates later in men than women. So for all those wives out there and women, yeah, men are slower to fully myelinate. I'm going to use that as an excuse going forward when you're disappointed in me. But this is truthful. And the interesting thing too to all of you listening in is that we know so little about how our brain works. It is the ultimate supercomputer. I have this up to remind us that the Human Connectome Project happening at Mass General has discovered, and it's really important, 97 new areas and 83 previously reported areas. We have all these 180 areas that are really important to how we think and function, including 97 new functional anatomic substrates in our brain. And they did this by using, again, the myelin mapping technique, task-related function MRI, which I'll talk about the next time if that interests you. We can talk about how you actually map motor function in the brain in terms of imaging. These things called connectivity maps. We actually are figuring out how our brain functions on a connectome level, like how does the left frontal lobe talk to another part of our brain? And it's actually mediated by white matter tracts and association areas. And these things are being mapped now. And this is why the myelin content varies. It depends on that functionality. You want to have a lot more myelin when you want greater speed, right? Particularly occipital lobe, you see danger, motor lobe, motor cortex, flight or fight response, whereas you want less myelin if there's more flexibility, plasticity. So you don't have to necessarily be so heavily myelinated perhaps in the frontal lobe that is centered around decision making, because maybe you want to take more time to decide things. So this is really interesting for us to think about anatomically. Here's a paper that detected cortical pathology that inspired us to do our own research by looking at non-uniformity in that myelin map, and can we generate some statistical information. So if you look at this, these are all the values in that ROI. You can see areas here that are 2 standard deviations below normal, and maybe that represents a plaque. So we looked at 20 patients with MS, 10 with migraine. You can get these myelin maps indicating areas of myelin loss or damage. And if you go back to the image, you can find all these cortical plaques, which I never would have identified prospectively. So it enhances our ability to detect cortical plaques. This is showing you the reduced cortical thickness modeled by cortical myelin and how that looks in terms of an area under the curve, mapping sensitivity with specificity, and that's a pretty good value. Above 0.8 is legitimate. So that's where we are with myelin mapping. There are 2 other techniques I'll talk about really quickly. This is called double inversion recovery, which again is really good at detecting cortex, but these images are really difficult to interpret. Here's another plaque, the arrow's off in the cortex. But these images are very difficult. It's a volumetric sequence. There are probably like 200 images per patient, and to look at that would take you an hour. So we're trying to work on artificial intelligence to automatically detect these for us. T-Monroe, I'm not going to spend too much time on for the interest of time. This is a sequence where we developed this when I was at University of Vermont. We actually sort of added onto a patent by developing ways to image this differently that were more sensitive to MS plaques. It's essentially kind of contrast that operates in a kilohertz range, not megahertz range, and you lock the magnetization of the magnet in a rotating frame, and you actually are looking at anionic exchange between bulk extracellular water and the protons of abnormal proteins that are accumulating in MS at the blood-brain barrier. That is a mouthful. I will not test any of you on that later. Let's get right to the study. We looked at MS patients compared to controls, and this is what it looks like. Over here, I want to call your attention. This is actually representing quantitative information in milliseconds. Essentially, when we do T-Monroe, we're imaging the volume of the entire brain, and every one of these colors represents a different quantitative value for that T-Monroe magnetization. It's in milliseconds. How long did it take to relax and regain normal signal? So it's quantitative study, and that's really important because we want to be able to quantify things to have better outcome metrics for MS. And we looked at their disability scale, the volume of disease burden was the same, age is pretty similar. And this just quantifies the different values. But the take-home point was that these T-Monroe and T2 values were increased even in the normal appearing gray and white matter in MS patients, and the T1 row, it was significantly higher. It correlated T1 values with the duration of disease. It also correlated with disability. Now, T1 and T2 are highly correlated because they both are measuring pathology, but in a different way using MR physics. What was interesting to us, and this is what I'm studying currently with a grant with a neurologist at Lenox Hill Hospital, Asaf Harel, I want to call your attention to this area here. Now, this represents, so we have lots of MS in the periventricular white matter in this patient, but those all have kind of a similar value on T1 row, but this one really stands out as an outlier. It's way off the chart. And our hypothesis was that this represents a more acute plaque. And there's a lot of interest in not using contrast when we image multiple sclerosis patients, because there's a lot of concern about gadolinium deposition, although probably less of an issue with macrocyclic agents. But contrast is expensive, it takes longer to do. What if you could just do a very quick sequence and get an answer about disease acuity or the acuteness of a lesion right away? So this is what the motivation is. And we've done 3 patients to date pre-COVID. And I can tell you that every single time that we see this outlier divergence, it corresponds to enhancing plaques. We have a study where we are taking patients with enhancing plaques and scanning them within 24 hours with this T1 row technique, and we have complete concordance. So this really is a very, I think, reliable way, and that is super hot off the press. And the last thing from Danny Reish at NIH, as MS patients get older in their 40s and 50s like I am, you also can have sort of normal processes of aging affecting your white matter. A lot of patients have hypertension or diabetes or other processes which could affect potentially white matter and make a little scar in the white matter, what we call gliotic signal. And it looks like a plaque. However, the plaques form around these deep penetrating veins where there's a blood-brain barrier there. So this represents blood-brain barrier breakdown along that perivascular space. Now, this doesn't have one. This is just a normal spot associated with either hypertension, aging, diabetes, very nonspecific, but that represents, a normal spot without a central vein. So this central vein is really specific to MS, and that's a new breakthrough. So I can answer questions in a second, but just to recapitulate, last slide about standardized reporting. So this is really not germane to the listeners, but in general, if you want to do very large multi-institutional research where you compare imaging, you want to have standard imaging across those different networks. And we do have a McDonald's criteria for diagnosing MS, but radiologists don't have consensus yet when we report on these cases, which I think drives neurologists a little crazy. So we are trying to come up with a standardized method of reporting. So if I develop like natural language processing AI programs to sort of extract data from MS reports, I want them to all be structured the same way, or I'm gonna have a really hard time. So if we were to structure a report, we should always mention things like enhancing lesions, the location of hyperintense lesions, where the new ones are happening, whether there's atrophy, and the appropriate descriptors. And I want an AI software to do this all for me. And here's just an X-Files case. And again, you have a very large expansile lesion, the pons, bright on flare, not bright on diffusion, funny looking enhancement. And we really didn't know what this was. We had a very long differential. We really thought it was going to be something like sarcoid or lymphoma. And it just turned out to be a very atypical presentation of multiple sclerosis. So again, we should always think about the horses first before we start jumping to the zebras, like we did here with sarcoid and other things. So today we learned about the McDonald's criteria for MS. And I think if you just left with the following things, this would be great as you go on to become medical doctors or neurosurgeons or neurologists or even neuroradiologists. If you see a lesion in the spinal cord, image the brain and vice versa. If you have a broken ring of enhancement, you should really think hard about demyelinating disease and multiple sclerosis. Diffusion imaging can detect the leading edge of myelin breakdown and loss. And the exciting thing to me as a neuroradiologist is that we have all this emerging MR technology that can look at cortical plaque detection, maybe disease acuity. It's a work in progress, but that's what I like living for. So again, I want to thank, well, not Boston University Medical Center, which is where I gave this talk. I want to thank, Dr. D'Amico and Dr. Bookvar and Lenox Hill for letting me speak about this. And I have a lot of collaborators at UVM, also in New York City, Donna Mishku was before Dr. Harrell's time, but they're both very excellent neuroinflammatory neurologists with an interest in MS. Trevor's at Washington University of St. Louis. Richard is at Yale. He's in Oregon. Andy was from Oregon, now UVM. So it just goes to show that there is no I in team, and that multidisciplinary collaboration is really going to be critically important to the future of medical research, and it's possible to do this. So thank you for your time. And if there are no questions, that's good too. You have an early break.
I'm going to open the chat up now, and the questions will come in.
Let me just do a, go back to Zoom for a second, wait.
Yeah, you could stop screen sharing.
Yeah. Let me stop the screen share. There it is, stop. Okay, great. All right. Okay, there's a lot in that chat box. Yeah, let me go to the first question. Oh yeah, okay, hold on. So there's some really, really good questions here. I'm gonna start from the, wow. Okay, there's a lot of really good questions here. So let me start with, so the reason why the plaques look hyperintense or bright or like a white color, it's a construct of how we do that MR image. And essentially, we use parameters to maximize the signal, the look, if you will, for edema. And when we generate that image or reconstruct it, every one of those voxels has a quantitative value, what we call a relaxation parameter. It's in milliseconds, and we just set it in such a way that things which have the longest relaxation time are going to be bright, and things that relax quickly will be dark. So it's a way to manipulate the mathematics of that MR sequence. But in essence, if it's bright or hyperintense, it's edema, water that shouldn't be there in essence. So it's kind of, and it happens to occur in very characteristic locations, which makes us think of MS. Peripheral demyelinating disorders can be harder to diagnose, which is absolutely true. So the peripheral nervous system, you have things like Guillain-Barré syndrome, where you can see enhancing nerve roots. That's relatively easy, but I will tell you that there are chronic inflammatory polyneuropathy demyelinating diseases where it's really, really hard. You want to look for subtle enlargement or enhancement of the nerve roots. It's often not present, even though the disease is present. So the peripheral nervous system is always like sort of the afterthought for neuroradiologists. I fall victim to this too. I mean, I think I can share some of that blame. You know, there are people very intensely interested in studying peripheral nerves with diffusion tensor imaging, but yeah, you're right. It is harder to diagnose it in imaging. I think that neurologists have an easier time diagnosing that because they can use EMG, you know, they can do studies to assess, you know, nerve conduction and function to understand that's really a peripheral nervous system disorder. I think that that's true. Yeah, so yeah, to differentiate multiple sclerosis from, so Guillain-Barré syndrome has a kind of very characteristic enhancement of the nerve roots anteriorly within the spinal canal in the lumbar region. MS in the spine tends to be very focal plaques. Now, if it's neuromyelitis optica spectrum disorder, it's long and segmental. And the cauda equina are the nerve roots that tend to be often involved with Guillain-Barré syndrome. It's what we call the horse's tail, those nerve roots, and it tends to be the anterior ones. Sanjay asked about leukodystrophies. Yes, leukodystrophies, I am a pediatric neuroradiologist as well, and they will show this hyperintense signal abnormality and subcortical white matter. It tends to be very bilateral, very symmetric, and we really rely on diffusion imaging to mark that zone of myelin destruction. Yeah, let me keep going back in time. Yeah, we'll get to, hold on. Risk factors to MS is mostly genetic. That's a Carmen Flores, very interesting question. It's interesting. There's definitely an association with latitude, so it is definitely more common in northern latitudes, multiple sclerosis. I think the genetics behind this are still very much being figured out. NMO, for example, has a much more common phenotype that's seen in Hispanics and Asians. And there's a lot of theory still about multiple sclerosis. I mean, still hypothesized there's probably some environmental factors, like where you happen to be living in terms of climate, like that northern latitude being more affected versus being exposed to some antigen. It crosses the blood-brain barrier and sets up an autoantibody process so that you have this loss of myelin that way. Are MS patients more likely to be a brain tumor? I am not aware of that. And I have to look that up. I am not aware of that. Why are young adults more commonly diagnosed with MS in other age ranges? That's a really great question. And I have never really been asked that before. You know, it is definitely something that we pick it up more commonly in the 20, 30, and 40-year-old population. It's unusual to present with MS de novo or for the first time in your 50s and 60s. Maybe it starts to reveal itself and you're sort of more fully myelinating or to the end of that myelination journey. Maybe, I don't know. That would be speculative. That I do not have an answer. So here's a really good question from Rebecca Sweeney. I would say that there's a new theory about neurodegenerative diseases like Alzheimer's, tau, multisystem atrophy, Parkinson's, and prion disease. All those diseases are characterized in some way by the abnormal accumulation of proteins, whether it's amyloid, tau, alpha-synuclein in Parkinson's, prions, MSA is a tauopathy, or is it synucleinopathy? But these are all sort of tauopathies, synucleinopathies, or amyloidopathies, if you will. But all these neurodegenerative disorders are felt to have some bearing to this glial lymphatic system. The glial lymphatic system is a way to have your brain get rid of the toxic sort of buildup of solutes during the course of the day. It is mediated by the CSF interstitial fluid exchange at the blood-brain barrier.